With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Okay, a very good afternoon to everyone. My name is Tien. I'm a pediatric surgeon from KK Hospital. I'm sure all of you are aware that it's not possible for me to finish a topic as complex as pediatric trauma in 25 minutes, so I'll just try my best to give you a simple idea. Okay, although the time is short, I would still like to spend a few seconds to talk through the history and evolution of the pediatric trauma care, as I believe the origin is always important. And sorry, the slide is not. Oh, it's okay. Sorry. So I believe the origin is always important, and probably that's the reason we went back and watched the first 3 episodes of Star Wars. Yeah, so we would like to talk about a little bit about the history. So the history of pediatric surgery, the history of trauma care actually has its root in the war, as expected, because the care for the soldiers actually led to the improvement of the team approach and the trauma care. Whereas in contrast to the trauma care in adult, the pediatric trauma actually sets its roots from a disaster in Halifax, where a French cargo ship with a high explosive collided with a Belgian relief ship in 1917 and caused a big, huge explosion in the harbor in Halifax. So this Professor William E. Ladd was a young general surgeon who volunteered to help out in the disaster. And after witnessing so many suboptimal care in those children, he decided to dedicate himself to pediatric surgery, and that is where the beginning chapter of the pediatric surgical care. And although pediatric surgery has already evolved and developed itself as a subspecialty over the years, it was not until much later that the pediatric trauma care developed. 1973, the emergency medical services was established in the US, but not until almost 10 years later before the EMS have added on a C for children to dedicate a structure to ensure optimal pre-hospital care for ill and injured children and adolescents. And it was not until 1982 that the first article described the standards of care for the critically injured pediatric patient was published. The World Report on the Child Prevention Injury stated that there are estimated 1 million children under the age of 18 years old annually suffer from injuries from the accidents. And 90% of these are caused by accidental injuries, with 10% caused by non-accidental injuries. And road traffic accidents are still the leading cause of death for the children and also the teenager. We had the review of our epidemiology of our pediatric trauma in Singapore, and we found that it's rather unique because we have actually very few pediatric trauma in Singapore, and also compared to the overseas center. This is probably because of our lifestyle that most of our children are busy studying to prepare for their PSLE, and also because of our successful injury prevention program that you can see all the soft mat in the playground all over Singapore, and also Singapore being a relatively peaceful society that interpersonal violence is rarely seen. And many of our pediatric trauma are actually isolated orthopedic injury like femur fracture or arm fracture. So as you can see, there are very few surgery being performed for our pediatric trauma in this study, and the mechanism of injuries are mainly actually accidents that happen at home. Sorry, the pointer. So you can see it's mainly happen at home and in the playground. We were fortunate enough to have an NUH colleague to support us to do a collaborative study, and the findings were presented in Singapore Trauma last year. This is a collaborative study to look at the epidemiology of the pediatric trauma in Singapore over the 4 years period. In a summary, we found that the fall was the most common mechanism of injury in children, followed by submersion, road traffic accident, and burn. More than 75% of patients had an ISS of 9 to 15, which is not too bad, and most of them were isolated orthopedic injuries. And mortality from the trauma was only about 5%, which is actually very low. The fall, most of them happened at home, so the next move is to improve the caregiver awareness in the future injury prevention program. And in a road traffic accident, we found that more than 55% of the patients who injured were pedestrian. And most of these patients were actually primary schoolers that walk home from the school, unaccompanied by the adults. And aware of this alarming risk, we actually have published this paper and also proposed that this has to be looked into in the future road safety campaign. So, what are the unique considerations for the injured children when the children really are not just little adults? The airway and the shock management are paramount importance. Children do die from hypoxia and respiratory arrest, and they are prone to head injury with increased morbidity and mortality. And when you have a force over the small area, you are prone to a multi-system injury, which is happening in the small little kids. They usually have a little or no external injury. And pediatric patient also prone to increased heat loss, glucose and fluid requirement, and not to forget the psychological sequelae that happen after that. So this illustration shows you the average multiple trauma victim injuries by the body region, head being the most common, followed by extremities, then chest and abdomen. Pediatric head injury is the number one cause of death due to trauma because they have larger head than the adults in relation to their body. The skull is more plastic and deformable and open suture function as a joint and allows shifting of the bone to absorb impact and prevent early and rapid rise of the ICP secondary to brain swelling and the space-occupying lesions. An infant can lose a significant portion of their blood volume into their cranium secondary to a head injury. Whether this actually causes a hypotensive episode or hemodynamic instability is still in a lot of debates, and there are certain studies that look into it. We've also found that these pediatric patients are at about 2 times risk of having cervical injury compared to the adults, because their C-spine is much more flexible than the adult C-spine. And also beware that this particular condition that usually happen in the children is a spinal cord injury without radiology abnormality. It's called Shivora. Any patient with a trauma-related myelopathy warrants an MRI. Pediatric trauma, thoracic trauma is the second cause of a trauma-related mortality because they have incomplete ossification of the ribs that make it very pliable, and you can actually compress the front rib to the back rib, like just press it down easily. So pulmonary contusion are very common in children, but rib fracture is rarely seen. So anytime if you notice there's a rib fracture in a very young children, it should prompt you to suspect of non-accidental injury. And a pediatric patient have a narrower, shorter trachea and is compressible. Any small changes in the airway caliber due to any external compression like blood clots or internal foreign body can lead to a large change in the resistance and pose a great challenge in the airway management. The pediatric abdominal trauma is the third leading cause of the pediatric trauma death. Blunt causes in 85% and penetrating trauma in 15%. Most of the patients, this is mainly because the children have a proportionally larger solid organ. They have large spleen and they have large liver, and they have less subcutaneous fat and a less protective abdominal musculature. So the seat belt injury and the handlebar injury are 2 of the common blunt injury that we see in the pediatric patients. And do not ignore this sign, especially the handlebar injury, because we do have cases that end up with very severe consequences. Well, one of the patients have a duodenal transection, the other one have a pancreatic transection. And the other unique things about pediatric patients is that they have a different response to shock. As in an adult, you can see that when you have a shock, you have a rise in the heart rate and a concomitant drop in the blood pressure. Whereas for children, the heart rate will keep going up and the blood pressure will maintain. And all of a sudden, at the point here, they will drop precipitously, and then patient will end up with a myocardial ischemia and multi-organ failure. So do not look for hypotension in children. Whenever you see a tachycardia, it's already an alarming sign. So the next question is when to transfer a patient to a trauma center. Where there are multi-system involvement, neurovascular injury, and an unstable patient that will probably require a pediatric intensive management, you should transfer them to a trauma center. And the other more objective guide, of course, is one of those trauma score that you use, either as the PTS, Pediatric Trauma Score, or Revised Trauma Score. PTS is one of the most common used and popular trauma score that have been used until now. It was first described by Joseph Tepas in 1987 and has been remained popular until now. In fact, in my hospital, we used it as one of the criteria to activate the trauma code activation. However, when we did a review 2 years ago to look at the PTS, we found that it was totally inaccurate. It doesn't predict the need for resuscitation, and it did not predict any major trauma in the children. So in short, it was totally useless for a local population. So moving from there, we started this project to try to identify what are the real factors that we can identify, what are the potential severe injury the patient to transfer to a pediatric trauma center. So we capture a patient for these 30 months to try to identify the factors. So with the aim to formulate a reliable pre-hospital triage system for the pediatric trauma in our local population. So this is what we do. We look at the SCDF record, all the observation, and also the first set of parameters documented, and also the GCS. So from there, we actually put them together and try to run the multivariable analysis. We found that none of the parameters stand out to be significant in predicting a need for resuscitation, whereas the simple observation by the paramedic as a significant wound, that means the paramedics go there and see, oh, this wound is significant. It actually stand out to be a significant factor to predict the need for resuscitation. Of course, GCS is another one. When we try to predict the major trauma, again, none of the parameters, that means all your heart rate, your respiratory rate, your SpO2, and your BP, none of them actually predict this patient may suffer a major trauma in the children. And just by looking at it, they think the patient may have a possible cervical injury, capillary refill is not good, or the skin condition that doesn't look good. Actually, it's a more significant indicators. This is the same as well as when we try to look at the poor outcome. So in short, the first impression by the paramedics actually predicted the major trauma and the need for resuscitation in a pediatric patient more accurate than your PTS score, which is quite interesting. So moving forward from there, we actually expanded the study to recruit all the other hospitals in Singapore, and we are still analyzing the data. Hopefully that we can finally devise a score that tailor for the local population and eventually can predict the unpredictable. So after decided to transfer, the next question is whether to transfer the patient to an adult trauma center or pediatric trauma center. So in Singapore, by default, the paramedic will transfer you to the nearest hospital with a trauma facility, and by default, all the tertiary hospitals have trauma facilities. So in theory, most of us will believe that in the pediatric trauma center where there's a better pediatric care, dedicated pediatrician, the patient will actually get a better care. But also the other group of doctors actually hold different opinion, especially the trauma surgeon. Because in general, the adult trauma surgeon will have much higher experience in the trauma care compared to the pediatric surgeon. So if a patient have a severe injury, whether they will end up in better hand in the adult trauma center or the pediatric trauma center is a constant debate. Certain paper actually try to seek an answer to these questions, but the results were actually quite contradicting. This paper by Patoka, published in 2000, showed that improved survival at the adult trauma center with a pediatric qualification and at a pediatric trauma center compared with the adult trauma center without pediatric qualification. Whereas another paper published a year later showed that the unexpected survival actually greater in the adult trauma center or the adult trauma center with a dedicated pediatric qualification in relative to a pediatric hospital. So that's why the interesting title says it's rated NC-17, which is 18 PG in our local population. So many of the literature also address that the reason that a pediatric trauma center or pediatric hospital can do better is not because of the surgeon, but rather because of the PICU facilities, the pediatric ICU facilities, and the dedicated pediatric ED resources. Because they believe that with the ICU and also the ED resources, it's easier for them to organize the EMS and also the pre-hospital stabilization team. In our context here is the CHATS team, to go to the hospital, stabilize the patient, and bring them back to our hospital for further management. So the questions remain unanswered, and I think the best answer to this question is that it's not really an adult trauma center versus a pediatric trauma center, but in our context here, it's a joint effort. For example, the pediatric surgeon can actually, or pediatric team, can move forward to the adult hospital if the patient is too sick to be transferred to help in the resuscitation, as well as sometimes we can call the trauma surgeon to come over if we have a complex case to operate. And another interesting thing we look at is that one of our team members actually carry out a review of the pre-hospital transport for pediatric trauma, comparing the private transport like taxi or private vehicles compared to the EMS, SCDF ambulance. And we found that in Singapore, actually majority of the patients of major trauma and unstable injury patient actually was brought in by private transport and not by ambulance. And more surprisingly, actually there's no change in outcome in terms of their hospital stay and ICU admission. So this is something quite uniquely happened in Singapore. I don't think anywhere else you actually have a major, very sick patient that actually being brought in by a taxi or a private vehicles. So when we talk about pediatric trauma, the next thing, of course, is the discussion about the CT scan, whether we are creating more radiation. Statistics show that there have been 700 increase in the CT scan in the past 10 years. The problem in the children, of course, they are much more radiation sensitive and they have longer life to develop a cancer. And the cancer incidence is 24% higher in the CT exposed children as shown by this report. As this is even increased with the additional scan and increased with the decreasing age. The younger you are, the higher risk you are. So the other paper actually reported there's a 1 fatal cancer per 1,000 CT scan in a pediatric patient. So this is something really, really significant. Another review performed by Fenton in 2004 shows that many of the CT scan actually reported normal result in the trauma patient. And even some of them have non-specific findings. They went in for a laparotomy and end up with a normal finding. So he actually argued that, he proposed that the CT abdomen has to be used judiciously. Our pediatric radiologist recommendations are irradiate only when and where necessary. So you don't do a PET scan. It's not like you do a CT thorax, then you at the same time do a CT abdomen because the dosage is actually very different. And we also have a pediatric specific imaging protocols in our hospital that actually has a much lower dosage compared to the other hospital. And we always advise to avoid repeat and multi-phase scans and consider MRI or ultrasound whenever it is indicated. So finally, we talk about the surgical management of pediatric trauma, cut or no cut. When I was a junior surgeon, I used to remember this joke told by my boss. He always said, when you are called to see a patient, you always have this thinking in your mind that whether this patient, I need to cut or no cut. If the patient doesn't trigger this question in your mind, this is not a surgical patient and suggest to refer to medical. So this is one of the quotes that I remember reading on my surgical atlas. A good surgeon knows how to operate, but a better surgeon knows when to operate, but the best surgeon knows when not to operate. So this is probably explain why every time I want to operate, my boss told me no. So, as all of us already aware, the non-operative management of the traumatized patient actually started from the pediatric population. This was one of the very first landmark paper published by the sick kid in Toronto. They actually shows a very good result of non-operative management in the isolated spleen injury. And since then, it has become a standard of care now for all the isolated spleen injury, even for the high-grade injury. The major concern of the non-operative management, there are a few things. One, of course, is the increased blood product because you have to keep giving the patient blood. Sometimes the bleeding may be still ongoing, even they are encapsulated, but they can bleed significantly. So you need to keep giving them blood products, which is not without risk. The prolonged hospital stay, and also some of the doctors will argue that you may miss an associated injury like hollow organ injury because you're no longer going in to explore all the high-grade solid organ injury. How would you know there's no associated bowel injury that can eventually lead to contamination in the peritoneum and peritonitis? So aware of this controversy, this landmark paper actually tried to address this issue. They studied 1,700 children in 7 pediatric trauma centers and found that the failure of the non-operative management in children was as low as 5%. And most of the failure that actually happened, it occurs within 12 hours after the injury. The failure is usually associated with multiple organ injury, greater injury severity, and isolated pancreatic injury. That means you actually have a patient that come in, even a high grade, but you observe them, if they are stable more than 12 hours, most likely you are safe and do not need to consider a surgery. The indication for surgery, they are the clear one, the hemodynamic instability in the patient, evidence of persistent hemorrhage or hollow viscous perforation. So these are the indication for surgery. Because of a lot of controversy that exists, the Association of Pediatric Surgical Association, American Pediatric Surgery Association actually published a guideline to actually give a recommendation about the duration of ICU stay, hospital stay, transfusion requirement, need for surgery, pre- and post-discharge imaging, and restriction of the physical activities after reviewing their trauma registry. So the recommendation is quite interesting. As you can see, even for the very high-grade liver or spleen injury or grade 4, they only recommend 1 day of stay in the ICU and total 5 days of hospital stay. So grade 1 to grade 4, isolated liver and spleen injury, all of them can be discharged within 5 days, and you do not require any imaging, and they can back to their normal physical activities after 6 weeks, even in the grade 4. And a few years later, they actually did a prospective study, and compared to the retrospective data, they found that the successful rate of the non-operative management remained high. They only need to operate about 1.3% of patients. The successful rate is about 90 to 96%, and the late bleeding is very uncommon or rare. Another study published 3 years later also produced similar result, which actually proved that a non-operative management is actually a safe option in a pediatric patient. In our own experience, we also have a look at our non-operative management. We have 17 patients collected in 3 years with all the solid organ injury. And the surgery that we perform, and 2 chest tube insertion. I think a lot of people will argue that this is not even a surgery, but we do have a real surgery that is a distal pancreatectomy for a pancreatic transection from a handlebar injury. There were 9 cases of a high-grade pediatric solid organ injury, that means grade 3 and above. The median ICU stay was only 3 days, and median hospital stay was only 10 days, and all the patients discharged without significant disability, and there was no mortality at all. So I would like to elaborate a little bit more about this particular case. This is an 8-year-old boy, cyclist, hit by rain, when then he sustained a grade 3 splenic laceration. So you can see from the CT scan, he has a blush somewhere in the spleen. So he actually required 8 units of packed cell transfusion, 8 units of FFP, and 3 units of platelet, which is a massive transfusion protocol. So in the hand of any trauma surgeon, this is the next appropriate move, probably would bring the patient to OT, operate, and then take out the spleen. But because this is a very young kid, we have a lot of conservation to the spleen, so we decided to go ahead with angioembolization. So there's multiple branches, there's bleeding. Our interventional radiologist managed to secure all the bleeding. 4 days later, because of the persistent HB draw, we have a scan repeated, and again we saw a blast. So by this round, should we consider surgery? We again decided to go ahead with another angioembolization, so the bleeding stopped, and the patient eventually discharged about 10 days later. And 3 years later, we have an ultrasound that showed a very good size spleen. And patients do not require any vaccination and do not need any prophylactic antibiotic. So this is a case to show you that in pediatric patients, non-operative management is really possible, even patients with a hemodynamic instability with a transient response. So in short, pediatric surgeon has a higher threshold to operate and tend to persevere with a non-operative management. However, that requires very close collaboration with our ICU and IR colleagues. And for this case, actually, one of the pediatric surgical team has been sitting in front of the patient, watching the vital sign very closely over the 24 hours. And the surgeon should be the one who makes the decision if the indication for the surgery arises. And because of the popularity of the non-operative management, some of the paper actually try to address the issue whether the pediatric trauma is really still a surgical disease or something we can be managed by our pediatrician or emergency physician and refer to us as blue letter when the need to operate arises. So you can see that there are a lot of debates going on, and there are a lot of papers published with a similar title. So in a nutshell, when it comes to trauma, the old says that the children are not just little adults. It's true. Their different anatomy produces different injury patterns from the adults, and their physiologic response to injury is different from the adults. The mechanism is not as predictive of a chest or abdominal trauma in children. The injured children will benefit from a systematic evaluation and management at a pediatric trauma center with dedicated PICU and dedicated children's emergency physician, as well as the pediatric surgeon. Always remember to avoid unnecessary imaging in children. And remember, there's a higher chance of success in the non-operative management observed in the pediatric trauma, but the surgeon should make the call if there are indications to operate. I would like to acknowledge the thanks to Dr. Jed Kwa and Dr. Chang Li Wei, especially to help me prepare the slide. Thank you.